The broadcast is now starting. All attendees are in listen-only mode.
Hi, everyone. My name is Adaira Landry. It looks like people are just coming on, and we wanted to welcome you to the first ever Ultrasound Case Conference. We are so excited to be partnering with Cosmos and Equanos to talk to you guys about cases that we see in the real world using their products. So again, my name is Adaira Landry. I am one of the physicians at the Brigham and Women's Hospital. I am a ultrasound fellowship director in our Department of Emergency Medicine, and I am joined today with Dr. Trent She.
Hey guys, Dara, thank you so much for having me, and thanks Cosmo and Echo News for letting me be a part of this. My name is Trent She. I am also an emergency med doc. I am in between jobs at the moment. I'm leaving as the ultrasound director at Mount Sinai Morningside and West in New York City, and I'm going to be moving to be the assistant ultrasound director at Hartford Hospital in Connecticut. And excited to be here.
Excited to have you. You are your inaugural guest to this ultrasound case series. And just to provide a little bit more context, so as ultrasonographers, we do a lot of QA. We review a lot of images on our own, but what we also do is review them together with our colleagues, and we discuss these images and how they are related to the patient care, and we review how to better optimize these images and sometimes bring in literature, and it's just a really nice discussion. And so we figure, why keep that just amongst ourselves? Why not bring in a greater audience? So that is the context for this series. So why don't we just go ahead and jump right in? We have three really awesome cases today prepared by Trent. He's going to be talking to us about the interpretation of these images, a little bit about how we can optimize them, and a little bit about the patient care as well. So it'll be quite interesting. So let's go ahead and jump right in.
All right. So I got this first case. So this case is a middle-aged woman coming in with progressively worsening shortness of breath for a month. And this was done maybe a couple of weeks ago during the height of the COVID pandemic. And so this patient has no past medical history and has tested negative for COVID twice outside the hospital. The really interesting thing at triage that I remember about this patient was that her O2 sat was in the 30s on room air. And amazingly, she was still talking to us. And so we moved her into our resuscitation room, and we started to take care of her. And whenever I have a patient that has undifferentiated shortness of breath, one of the first things I reach for is my ultrasound. And we, at this stage of the pandemic, we were pretty well aware of the association between COVID and pulmonary embolism. So one of the things that I was concerned about in this hypoxic patient that had COVID was, does she have a pulmonary embolism? And so what we started to do was we were doing our bedside cardiac echo for shortness of breath as the indication. And in this image that you see here, this is an apical 4-chamber view where you're trying to see all 4 chambers of the heart. And the biggest thing that I'm looking at here is the right ventricle size versus the left ventricle, but there's of course a couple other things that I could be looking at: presence of pericardial effusion, left ventricle systolic function, of course presence of cardiac activity. And yeah, so it was a patient in really profound hypoxia that I'm leading this to. And this is the image that I obtained from that patient.
Yeah, and so I like that you started off with the apical 4, which is great because we can see the chambers, we can compare the chambers to each other. If you're concerned about this acutely hypoxic patient, usually our first differential is going to be in most patients, it's going to be PE. Obviously now we're caring a little bit more about COVID, but we're going to be thinking about that. And this view is really nice to get a great look at the RV in comparison to the LV. So let's take another look at some of the other images you went through.
So yeah, so
go ahead.
Oh yeah, I don't know. I was just gonna say, as we move on, like this view, I didn't get quite as clear a view in the right ventricle as I would like in the previous view. So in this view, I'm trying to get a better view of the right ventricle. And one of the things you can see subtly here is this thing called McConnell sign. And what McConnell sign is if you see the very apex of the right ventricle there, you see how it's moving, but that the free wall is not moving as much. And that's a sign that's fairly specific for pulmonary embolism, especially when you see RV dilation. And so that's one of the things that I was looking for in this particular ultrasound. And you also know that the RV is fairly large compared to the left ventricle. So yeah, it's just it was definitely leading me down the pathway towards considering whether or not this patient had a pulmonary embolism.
Yeah, and so were you thinking that this view was an adequate view to make that kind of decision, or were you looking for more images?
Yeah, so that's a great question. Typically, when we look, one of the mantras that my ultrasound fellowship director taught me was that when you only have one view, you essentially have no views. So it's always good to get multiple views of the heart. I think personally, apical four-chamber view, because it sees all four chambers, you can see right and left ventricle. You can compare the two sizes really well. Unfortunately, not pictured here in our image set. I did get parasternal long and parasternal short images as well, but this image was the one that I wanted to focus on for this particular patient.
Yeah, I think the one thing, Trent, though, when you're doing this image that could have helped you a little bit is trying to get this septum right here. You see it a little bit oblique, trying to get that a bit more vertical so you can get a better accurate assessment of the right ventricle compared to the left ventricle, for instance. Right now, it looks like it's a little bit off axis, potentially rotating a bit more laterally would have helped you sort of straighten this up a bit. So, okay, so now you have totally this apical 4. And then what's happening with this patient now? Because now you're getting, looks like a lung ultrasound.
Yeah, so we moved on from the cardiac ultrasound. We see the dilated RV, McConnell sign, theorizing that this patient's hypoxia, it was from pulmonary embolism. But then we move on to a lung ultrasound, and this view is at one of the apices of our patient's lungs. But I can tell you that this view pretty much matches all of the views that we got of the lung. It was just diffusely this kind of image right here. And what you see here is you can see that the pleura is moving. That's that big, shiny, hyperechoic area up top. And you can see those really bright searchlight looking things coming down from the pleural line. Those are B lines and generally representing some form of edema in the lung itself. And you know, this finding here was pretty odd to us because usually pulmonary embolisms don't cause diffuse B lines and diffuse pulmonary edema. It was honestly an odd finding to see.
So if I'm understanding this correctly, this patient came in acutely decompensated, dyspneic, hypoxia. You initially get this apical 4 view that shows this large RV with McConnell sign, which is pretty specific for a pulmonary embolism. Then you slam the probe onto their lung fields, and now you're seeing diffuse pulmonary edema or B lines, which could be pulmonary edema, which could be fibrosis, which could be a pneumonia, but probably we're thinking fluid in someone who has an acute change. So what were you thinking as far as the next steps? Because this is kind of tricky. You know, when I'm thinking of acute decompensated hypoxia or respiratory failure, especially in this, it's like, well, are you going to heparinize this patient? Are you going to put them on BiPAP and start nitro? How are you sort of working through this?
Yeah, no, that's a great question. Our initial thought was, what threw us a little bit is this was during the time when we had seen quite a few patients in New York City with COVID, and we were seeing a lot of this type of lung ultrasound with COVID. And the kicker in the story is our patient tested negative for COVID twice, and so we were initially thinking we were thinking away from COVID, but going back to the heart, if we were thinking that the left side of the heart looked like the function was normal. We didn't see any signs of chronic congestive heart failure. And so we were thinking that potentially she was one of those patients that had a false negative COVID test, unfortunately for her twice. And she happened to have COVID. And because of the association with COVID and pulmonary embolism, we were concerned, oh, like maybe she does indeed have COVID and she has a pulmonary embolism because of that. And so we did exactly as you mentioned. We started her on heparin, we put her on BiPAP, and we said, okay, we gotta get the CTA as fast as humanly possible.
Yeah, The only critique I have for this image, I think this is great if you're looking for just B lines, but if you were looking for someone who's acutely decompensated with this O2 sat of 30 and you're concerned about this pleural line, feel free to always decrease your depth and really zone in on that pleural line, especially in cases that are, you know, it's quite unclear. That'll allow you to really see if that pleural line is sliding. Now, the presence of B line effectively rules out a pneumothorax, but if you didn't have all these B lines and you were concerned, you definitely can zoom in a bit on that, or decrease your depth and zoom in a little bit more on that pleural line. So what did you end up doing? So you said you ended up doing heparin, and did you guys end up scanning her?
Yes, so we did end up scanning her. Yep, we did end up scanning her. We had ICU come down midway through our evaluation. She was stable on BiPAP. We did eventually get a CTA, and oddly enough, the CTA didn't show any signs of pulmonary embolism, but it showed this really odd finding in the tip of the right ventricle. There was this area of incomplete filling, suggestive of a right ventricle thrombus on the moderator band itself. And there was some RV dilation that was seen on the CTA as well. And the first thing when you get like an odd finding like that, or the first thing that I think when I get an odd findings like that is like, really? So I actually go back and I re-ultrasound the patient, and I'm trying to convince myself that that little area in the apical portion of the right ventricle, is that her right ventricle thrombus that's there? And so our hypothesis was she had this RV thrombus that obstructed the outflow of her blood from the right ventricle. And we were like, well, this potentially right here could be the cause for RV dilation and potentially her shortness of breath. So it's like probably the most proximal version of a pulmonary embolism that you can have.
Yeah, that's really interesting. I don't think I've ever seen a case like that. I mean, I could have easily looked at this and thought that was the moderator band that you can see in the RV that we wouldn't think anything of. So I like that point of going back. So the ultrasound is not necessarily a one-time thing. You can go back and reassess your patients, especially as new information comes in.
Yeah, I think that looking at this image like the first time around, there's no way. Like I would have called that moderator band like 99 times out of 100. And it was only on the CTA where I was like, really? And eventually our patient does get admitted to the ICU, and the next day ultrasound done by the echocardio, the echo lab shows that there's this RV thrombus. So it was just something I'd never seen before either. And I was just like, wow, like it's just, I just had to go back and take another look.
Yeah. Let's take a look at the next case. This is a really interesting one too.
Yeah, so this case right here, it is a elderly female found down in her apartment, and she comes in, she's profoundly altered, not giving us any history at all, a little bit tacky, not hypotensive, and essentially we have no history other than the EMS found her down next to her walker in her apartment. And we go through our exam and we realize that she has a fair amount of abdominal tenderness, which was really the only finding after we like flipped her and listened to her lungs. And so being that we had no information, one of the things we decided to do was we decided to just get our bedside ultrasound and see if we could find a cause for this abdominal pain.
Yeah, I mean, I can't emphasize enough that elderly abdominal pain, you know, you can wait for the CAT scan, but if someone's not looking great, it takes 2 minutes to just throw the probe on their belly. So in this case, you know, I'm looking at this and I'm seeing something here that could be, you know, could be a cyst, it could be a kidney. One thing that kind of tips me off is potentially this is the vertebral body here. And if that's the case, we know from anatomy that right above the vertebral body is a particularly large and important vessel, the aorta. And so I'd be concerned that there's something going on with her aorta that caused her to fall down.
Yeah, absolutely. I think one of the things that I probably could have done a little bit better in this view is I think when I was doing the scan, one of the first thoughts is, okay, something about this is abnormal, but I'm not quite sure what it is. I think I could have spent some more time and scanned through the images a little bit slower. Here you see an image of, this is a sagittal clip of that same odd looking structure. And yeah, we felt the same way as you. We thought, okay, this looks awfully like a AAA with some thrombus in it.
Yeah, and one thing you can do that would help, when you're doing the QA process, let's say you're scanning and someone else is going to be reviewing your images later. If it's an odd finding, you can always take some time and write a little bit of an annotation here that will just let them know I'm in the long axis right now, I'm in sagittal axis, this is the upper quadrant. Those sorts of things will be very helpful for us as we review.
Yeah, I feel like I tell the same thing to my residents, and here I am committing that sin where it's just like you have this image and you're just like, oh, like what is this?
Yeah. So it looks like you're getting another view here. I mean, this kind of goes back to your point earlier. This is a 2-second clip. You can always lengthen the clip length just a bit so that you can really take your time going through these images. We like to see the clip not in the screen, and then as you fan, it appears. You fan all the way through it, and then it disappears. This way we get a great understanding of what it is you're looking at. Now, what's all this? I'm seeing, okay, so this is the vertebral body here. This is the vessel. I'm seeing these hyperechoic things within this massive structure. Like, what were you guys thinking this is right now? These little hyperechoic white lines.
Yep, we saw that just as well, and we initially thought that this could just be calcifications in the wall of the aorta, just because she did appear to be such an elderly patient. Eventually, like same thing for this patient, we rushed her to get a CTA because we were concerned about that we had a AAA that was ruptured or leaking, and it turns out those hyperechoic areas were from a previous operation. She has an endograft, and those really bright objects, now that I look back on it, they don't quite look like calcifications. They look like the tips of the Gore-Tex that's used in the endograft. So it turns out that on our CTA, she had a AAA that was status post-repair. And eventually we do get some more history. We managed to get into contact with a family member, and well, she had a AAA status post-repair. This turned out to be a chronic finding.
Awesome. And so you could have stopped scanning there, right? And then potentially that would have been the end at the bedside. But you guys actually kept going on, which is quite interesting. And you found something that I don't think anyone was expecting.
Yeah. So
what is this?
This I actually have to thank my resident for, because my resident didn't stop scanning at just the aorta. He recognized that the aorta was an issue and then continued to scan downward. And I was like, huh. So this is right below the aorta where her bladder should be. And in the bladder, first off, the bladder is pretty distended, but we noticed that there's this layering, like hypoechoic sediment looking type of thing on the posterior wall of the bladder. And I gotta say, like, normally I see those in male patients when they have enlarged prostates and there could be some blood that's retained in the bladder, but this was a female patient. There's no prostate that you see in view. And so we knew for sure that this was a dilated bladder. So we ended up getting a Foley catheter in the patient, and it turns out all that sediment echogenic structure there, that's all pus. That is frank pus just sitting the posterior wall of that bladder. And you know what? It turned out, common things being common, our elderly patient who had a fall had a really, really significant urinary tract infection to the point where we could see all the bacteria growing on ultrasound, which is, I've never seen that before. That's crazy.
Yeah, and just thinking about areas of improvement here, one thing you could have done for sure is turn down your gain, just overall, especially here in this like sort of midfield. It's just a bit bright. And the downside of having too much gain is that sometimes you can miss some free fluid or those sorts of things hiding around the bladder. The other thing you could have done is potentially put some color here over this massive structure, just to make sure that wasn't some mass or cancer before you start manipulating it. And if you saw color flow, that would be less likely for it to be pus, for instance. Just two other things that you could have added onto your scanning.
Yeah, absolutely.
So
no, I totally agree. Yeah. I totally agree. It was just a crazy UTI. So
UTI. What about this case?
It's just you think it's AAA, and it's of course UTI. Anyway, this case. So this patient is another young male that comes in. He's coming in active cardiac arrest. CPR is happening. Patient's intubated, and all we get from EMS is that the patient has a history of asthma, and he's pretty much intubated. We have no history. I would say he looks like in his 30s or 40s. And so I personally think that ultrasound should be used in every single cardiac arrest, because when the patient doesn't give you any history, it's very, very important to know what's going on with the patient's heart, lungs, IVC, trying to figure out causes to why your patient went into arrest in the first place.
So were you doing, at this point, were you scanning to see if there was just contractility? Was this like a pulse check, or were you actually trying to see if there was an effusion? What were you hoping to find here?
Yeah, I think so. Right here, this is the scan during our first pulse check, and I think that this is the area where like doing scans is really important, because if you are doing your first pulse check and you see that there's a fair amount of cardiac activity, that kind of portends how well your resuscitation is going to be going. But if you see that there's like absent cardiac activity and just stagnant blood flow in the right ventricle, like you're probably looking at a very poor prognosis there. So yeah, but this was during our initial pulse check, and well, we see here what looks to be a perfusing heart, and so it kind of like gave, I think it kind of gave like the person who was on the pulse, when we saw this image, I was like, hey, there probably should be a pulse with this ultrasound image, and it turns out the patient was perfusing at that time and did indeed have a pulse, and we got ROSC.
Did you guys have any thought about what's going on on the right side? Were you thinking that that was clotted blood, or fruit? Like, what were you?
Absolutely.
Thrombus?
So, yeah, so we saw that, and we saw that there's, first off, the right ventricle you see again is fairly large, and you see that there's some kind of material in the right ventricle, and of course, pulmonary embolism, with that potentially being a clot in transit, is on our differential, and we were thinking about pushing TPA until the patient regained a pulse, and the patient right now is just too unstable to go to the CT scan. The other thing we were thinking it could be was just we were infusing a lot of pressors, fluids into this patient, and so we were thinking, okay, could that just be the medication we infused? Of course, we were also thinking that, is there some other obstructive cause causing that right ventricle to be dilated? PE could be that. This patient's chronic asthma, longstanding asthma, can also cause the RV to be dilated. Cardiac arrest itself could cause the RV to be dilated. And we were also thinking, could this patient like have some kind of pneumothorax? That can also be a type of obstructive shock. So the first thing we noticed with this was like, there's definitely some cardiac activity here, so that's good. And now we have to figure out, why in the world is this RV so big?
So this is a perfect example. I mean, you have 3 or 4 different diagnoses at the top of your differential. All of these can be evaluated with ultrasound. So let's see what you did next.
Okay, so this image here is just a still M mode clip of us on the patient's right apex. And what we're looking for here is we're looking for something called the barcode signs. And what that is we're looking for pneumothorax. And what happens is, if there's no motion in your lung field with M mode, your image that M mode acquires pretty much looks the exact same on the top and bottom. And it looks like, based on other movements, it almost looks like there's a barcode coming down. So if you see in like the middle there, you can see that there's like these lines that transverse, that cross the entirety of the image. So this was definitely something that we were concerned about, that could this patient have a pneumothorax based on this clip.
Yeah, and if, you know, some people find these barcodes to be a little bit confusing, and sometimes actually doesn't help with them. So you could also just take a clip of the pleural line and see if you see any sliding, which I think you do next.
Yep. And so
looking
here,
yeah.
Go ahead.
No, I was just going to say, looking here, we're trying to see, this looks like the most hyperechoic line, which is going to be your pleura. Were you guys thinking that this is sliding? I mean, this is really tough.
Yeah, I think the tips that you had mentioned before, like we could have done a couple things different with this clip. First off, it ended up being really tough to tell, but decreasing our depth so that we get the pleural line in the center of the structure, turning our gain down so we could see pleural sliding. Even then, to me, it looked like minimal to no motion on this, and it was a hard call. And I think that this brings up the fact that there's another beautiful part of bedside ultrasound, in that you have your patient there and you can make other assessments. And so we listened to the patient's lungs, and he actually had bilateral breath sounds. And so we didn't see very much lung sliding at all in either side of the apex, in either the right or the left. And so we were thinking, okay, this is weird. He has bilateral pneumothoraces, but he has pretty good breath sounds that we hear. And we didn't want to particularly go and perform bilateral chest tubes on this patient. So we ended up getting an X-ray, and they had good lung findings throughout. And we ended up saying that there actually wasn't a pneumothorax. This patient just had ultimately really, really bad asthma that caused him to just have such a prolonged expiratory phase that he just never really had great lung sliding to begin with. And it's one of those things where, like, I agree, like this is hard to tell. It's I think that we fortunately had the patient there and we had other clinical pictures, but the image is really hard.
This is tough, and I don't think if you guys had put a chest tube or a needle decompressed on both sides because of the absence of lung sliding in a tall, thin male who was a cardiac arrest, and you're seeing no lung sliding, I don't think you would be faulted at all, because I mean, this is like, that would be like the natural next step. It was probably only because you guys were being very thorough, reevaluating the patient's lungs again and saying, wait a second, but why am I hearing some level of aeration, that you got the X-ray. But technically, some people might have just stopped here and done a needle and have performed a needle decompression, wouldn't you say?
Yeah, no, it's definitely one of those things that I actually wanted to get your opinion, Dara. What do you think if you had this case, young male, cardiac arrest, known history of asthma, you see that big RV and you see poor lung sliding? I don't know, what do you think you would do? Would you? It's so tough because we were thinking about it.
Yeah, because with pneumothorax, sometimes you can see more like your A lines can become a little bit more prominent as well. And so these A lines here are pretty prominent. I bet I would have needled him. I think I would have, but I would have been wrong, right? And so I mean, I wouldn't have treated the underlying diagnoses. This guy would ended up needing MAG, albuterol, epi, and those sorts of things, I assume. And so it would have been the wrong treatment, but I don't actually think it would have been the wrong intervention, because most people would have gone down this track, and it's not unreasonable. So this is the interesting thing about ultrasounds, that sometimes it can really just help clear up a very, very, very clouded picture when there's so many diagnoses, and then it allows you to go back to the patient, start from the beginning, and say, what are the obvious truths that we have in front of us? And the biggest one was that you had lung sliding. I'm sorry, you had lung noises when you auscultated.
Mm-hmm. Yeah, we have actually a question from one of our attendees saying, isn't catching a lung point essential to rely on finding a pneumothorax, particularly in patients in cardiac arrest, where you can see some bubbling in the ventricles on their cardiac view? So, yeah, I mean, I think one of the other things that I could have potentially done here was just look all throughout the different lung segments, see if I could find a lung point. And I think maybe we closed the loop a little bit too early, just seeing only the apices and not going further on down the lung.
I wouldn't rule out a pneumothorax though if you can't see a lung point. It's not that sensitive. You have to find that spot, and so it helps you with ruling in for sure, but I wouldn't necessarily use it as a rule out tool.
Yeah, no, I agree. It's very specific, but not sensitive. And to answer the first part of the question, is it common to see some bubbling in the ventricles during CPR? I definitely have seen some material pass, especially if you're infusing agents into the right ventricle. But I think it's less so the infusion in the right ventricle and more so the fact that the RV is pretty dilated on that initial cardiac view that leads you down all of like this entire pathway. Wow. And so, yeah, so our patient ends up getting admitted to the ICU and further treated for just an asthma exacerbation. And he does eventually get a CT scan up in the ICU, which was negative for pulmonary embolism and also COVID negative. And so we chalked it up eventually to a really, really severe asthma exacerbation.
Have you ever seen this before? Or did you look through any literature and find anything as far as this being a common?
Yeah, so I was like, no way, like it doesn't look like there's lung sliding at all. And I did look up some cases of, there are some examples of when you have absent lung sliding. It doesn't necessarily mean pneumothorax, like patients who've had that surgery, who are main stem intubated in the other lung, they won't have lung sliding either. But there are some sparsely lit reports that in severe asthmatics like this with prolonged expiratory phases, you can see just very minimal movement of the lung. But I don't know, I think in a patient with cardiac arrest, this is one of the things that me and my residents were going back and forth on. It's like, do we just go for do bilateral finger thoracostomies into chest tubes? It was just, it was really difficult. And I don't know, this is one of those cases where you're like, fortunately, we didn't end up doing bilateral chest tubes on this patient, but one of those cases where you think about this ultrasound and you're just thinking about it, second guessing.
Yeah, and it's, I mean, I think, yep, like I said, I probably would have put some chest tubes in, but I think it's totally fine that you took your time and ended up getting the right diagnosis. So just to recap, we saw some really interesting cases today. We saw the RV thrombus in a patient that ended up ultimately having COVID and pulmonary edema. We saw a patient that presented with elderly pain and ended up having a UTI, but threw us for a loop for possible AAA. And then lastly, we saw a young guy found down with what looks like absent lung sliding that was ultimately secondary to asthma. All of these cases were really centered around the use of ultrasound. And so you can see how having this in your hands at the bedside, within minutes, you can really further along the care of the patient. So nice job, Dr. She. This was amazing. And thank you all for watching.
Thanks, guys, so much. It was great being here. On the next slide there, I think if you guys have any questions for us, please feel free. You can contact us either on Twitter. You can search for either of us. We're both easily found. And yeah, join back in for more case conferences in the future.
Thanks again, everyone.